Hi, my name is Tim Blackwell. I'm a fourth-year medical student at Rowan SOM. I'm presenting a case with Dr. Ingersoll and Dr. Blackwell. This was a 71-year-old female who presented with ILH, which is a very rare cutaneous condition that was initially described in 1994. Usually appears as a red to violaceous patch or plaque, usually on the extremities. And as you can see from these pictures, it was actually in the left lower face, which is very rare and led to a very difficult diagnosis. It also has a lot of associations with different diseases, rheumatoid arthritis, also orthopedic implants, chronic inflammation, underlying malignancies. So we're presenting this case. She initially presented to a different dermatologist's office with this similar lesions that you can see on her face. It was a red to bright. It was a warm, tender plaque on the left lower lip. Her past medical is significant for 50 pack years of smoking, psoriasis, and a hospitalization with Legionnaires a year ago. She was initially treated with an infection, then went to go see an ENT. She didn't have any, she had a complete negative workup. She had a CT of the face and sinuses, all negative. 6 months after this initial presentation to the first dermatologist's office, she presented to our office. So now, at that point, there's a 7-month history of this red, violaceous, blanching edematous, mildly tender lesion covering the lower lip and extending actually go into her chin and anterior neck. Intraoral exam was negative. On this clinic visit, initial thought was possible malignancy. A 3 millimeter punch biopsy was performed. This was initially read as a glomeruloid hemangioma, which on path report, workup for Palm syndrome was initiated. Any screening for cancer at her age was also initiated. 3 weeks later, and then another punch biopsy was performed, sent to a different lab, and also the initial 3 millimeter punch biopsy was sent out for a second opinion. So these were now read as consistent with IV, which is intravascular / intralymphatic histiocytosis with features of granulomatous vasculitis. So this patient was also sent to a different clinic for second and third opinion, and also confirmatory biopsy of the left chin, which agreed with the second reading, which was ILH. Her labs showed hemoglobin was 16.6. Her CA was high, was 6.4, but ANA and ANCA were negative. The patient also had an MRI done, showed asymmetry and no abnormal soft tissue mass or lymphadenopathy. So this is, it was a very interesting case. We didn't really know, there's not much literature on how to treat this. So we started first with tacrolimus, 0.1% ointment twice daily. The treatment didn't work. The lesion didn't shrink, but it did not grow. So once the final diagnosis was made, then she was switched on to oral pentoxamine and topical steroids, as well as topical tacrolimus. Patient then was on this treatment for about a month, and there's no improvement. So based on our literature review, we found that TNF alpha inhibitors might actually work really well. So we are going to start her on that. We're presenting this case because it is really rare, but it's really interesting and something that is definitely a diagnosis of exclusion. But if there's treated for a possible infection or malignancy and all those are ruled out, this is something that could definitely be on the differential. So we reviewed the literature, and there was a review of 16 cases that was actually published, and most of these cases were seen on the extremities and the breast region, which is why this wasn't initially high on our differential even after many things were ruled out. There's also this association that was consistently talked about with an association with RA and orthopedic implants. She didn't have any of these, so this is why this diagnosis was really tough. She does have psoriasis. She does have a 50-pack year smoking history, so maybe this was leading to a possible chronic inflammation plus malignancy. There's a lot that was going on in our differential, and which is why we got so many opinions on this biopsy read. upon a literature review, we were looking also for treatments of ILH because she was really worried that this is possibly a malignancy. Also, it's on her face. It's a very important cosmetic area. She just didn't want this to grow. So we were looking through all of PubMed and looking at any different kinds of treatments. And there were some treatments if the patient has RA that work better. Initially, we found that the TNF alpha inhibitors seemed like it was becoming a newer treatment and really working with patients with RA, but our patient did not have RA. There was also some patients with lung adenocarcinoma that were treated with a chemotherapy, and it also led to the improvement of ILH that the patient had. So these were all things. So we didn't know if it was, hey, if you treat the underlying disease, this ILH will also go away. We didn't know what was happening, which is why we initially started her on pentoxifylline, and then initially switched her then to TNF alpha inhibitor. Other treatments that we found: cyclophosphamide, topical and systemic steroids, amoxicillin, NSAIDs, topical tacrolimus, and methotrexate. So it's a really wide range of medications. So thank you. We're presenting this case, and I hope this teaches everyone about this rare disease. Thank you again. Please email me if you have any questions. Thanks.